So hi, you guys. Welcome. My name's Emma, for those of you who don't know me. I'm a fourth-year medical student. Feels like just 2 seconds ago I was a third-year medical student, but I guess it wasn't that many weeks ago. So how's third year going? It's a nice way to start on psychiatry. It's a pretty sweet life. So good. No one's been too mean to you yet? Very nice. The psychiatry people are all very nice. So it was my hello. And hello, friends in Harlingen. How many friends do I have? Three? Four? I don't have my glasses on.
3 for now. We got another one coming.
Fair enough. Okay. So I wrote this review actually in preparation for my own Step 2 exam that I took about 3 weeks ago. And I did these because OB-GYN, there's a faculty who gives a shelf review a couple days before the shelf, and I found it really helpful before the OB-GYN shelf, and I was like, why don't we do these for all of them? So I talked with Dr. Hinsey, and his office agreed to sponsor these shelf reviews. So it's the first time we've done them. I just wrote them about a month ago, so any feedback you guys have would be very helpful. And I wrote these, or I made these PowerPoints based on notes that I took when I was in the clerkship. So I'm a little bit anal, and I usually read about 3 books per clerkship and made a little review for myself. So going back to these notes, what I had read in preparation for my shelf exam, that's how I got the information that's in these PowerPoints. So it wasn't verified by Dr. Schillerstrom. This is just all from my own notes and my own reading. So as far as I know, it's accurate and correct, but it hasn't been fact-checked or edited by a bunch of people. So those are my legal disclaimers. All right. And this review is kind of set up in a question-answer format. They're not multiple choice because that would take too long, but it's kind of like question and then short answer. So it's designed, hopefully, that you guys will participate with me a little bit. Shout out an answer if you know it. Harlingen, you guys too. I'll start picking on you if I don't hear you answering questions from time to time. And hopefully I've designed it so I hit all the high points of psychiatry. Obviously I couldn't get everything in here or else it would take a lot longer than 2 hours, but I tried to hit the high points, the things I remember being relevant on my shelf. And as I'm sure you've been warned, the tough part about the psychiatry shelf exam is not the psychiatry, right? What makes the psychiatry shelf exam tough? All the medicine. So I tried to gear this review towards the medical questions they could ask you about psychiatry. Because I know the psychiatry faculty are great. They taught you the psychiatry you need to know if you've been treating patients. Some of the medical stuff is where it gets tricky. So I tried to focus on that. Any questions before we get started? All right, let's party. High-yield psychiatry. So a smelly 20-year-old college kid's grades have been declining over the past 2 semesters. And he keeps to himself. He has a flattened affect and no motivation. And for the past 6 weeks, he's locked himself in his dorm room, stating President Obama put a hit on him. He was told this by 2 voices having a discussion in his head. So what does he have? Schizophreniform or schizophrenia? How do we tell? Time is key for all of this DSM-4 stuff. So what's the time criteria for schizophrenia? 6 months, exactly. And what has to go on for 6 months? The positive symptoms or any symptoms? Any symptoms. And usually it's the negative ones that will predate. So in this vignette, does this kid meet criteria for schizophrenia? He does. You see, for the past 2 semesters, he's been kind of having those negative symptoms. So the diagnosis here is schizophrenia. And more specifically, he would qualify for the paranoid type, right? He's got persecutory delusions. And the paranoid type is both the most common type of schizophrenia. Sometimes they ask about that. It's also got the best prognosis of the subtypes of schizophrenia. So these are some random number questions. You'll get a few of them on your shelf: incidence, prevalence, and risk for family members. So let's prepare ourselves for those. Prevalence in society?
1%.
Very good. Between 0.5 and 1%. Good. 1% is a good guess for most of these. Have you noticed that? So between 0.5 and 1% is the prevalence of schizophrenia. How about the risk for this twin brother who brought him in? What would you say? 40? Close. 50. And a sibling, a non-monozygotic sibling? It's between 1 and 50, I'll tell you that. 10, very good. So 10% risk of siblings. And the neurobiology. Now we got to go back to Dr. Keaton's class back in the day. So where do the positive symptoms come from in schizophrenia? Too much dopamine where? In the mesolimbic tract. Very good. And what about negative symptoms? Where do they come from? And is it too much dopamine, or what's the story in the mesocortical tract? Not enough. Very good. That's why typical antipsychotics actually worsen negative symptoms, because they block dopamine everywhere, and when you block dopamine in the mesocortical tract, you're actually going to worsen them. So, very good. Oh no, you've seen this picture before, I'm sure. So these are the 4 different dopamine tracts in the brain, and this is important for us because the 2 that we discussed, the mesolimbic and the mesocortical, both affect the positive symptoms and the negative symptoms of depression. And the other 2 tracts, tubeo-infundibular and nigrostriatal, are going to mediate some of the side effects of antipsychotics. So just remind yourself of these little tracts, and always be thinking when you're studying the drugs, the antipsychotics, how they're going to affect each of these tracts. And we'll see that in the coming slides. All right, so now we've got a patient. He's got delusions, hallucinations, and flattened affect for 3 weeks only. What's the diagnosis here? Yes, so this is a brief psychotic disorder. If it's more than a week but less than a month, that's the little box that fits in. So brief psychotic disorder is the shortest duration of a psychotic illness. What if it lasted for 3 months, these same symptoms? Here's your schizophreniform. And how would we treat these? Absolutely. So we would still treat them with antipsychotics, and we'd use a typical antipsychotic first. And typical antipsychotics would help this patient how? It would help the positive symptoms. Would it prevent progression to full-blown schizophrenia? No. So that's important to know. Although with schizophreniform or brief psychotic disorder, you can use typical antipsychotics to treat the positive symptoms that they're having by blocking the dopamine receptors, it does nothing to alter the natural history of the disease. To my knowledge, there's nothing that does. So what if we have a patient who has persecutory delusions for the past 3 years, but then 6 months ago started having sadness, guilt, insomnia, decreased concentration, and suicidal ideation? So what's your differential diagnosis? You sick of that question yet? What's your differential? Schizoaffective and psychotic depression, I think, would be the 2 on the differential. So when you're trying to determine between schizoaffective disorder and depression or bipolar disorder with psychotic features, how do you tell the difference? Exactly. So which comes first? Which one is there in the absence of the other? So here we have psychotic symptoms in the absence of mood symptoms, so that's schizoaffective disorder. And remember that this can happen either with depression or bipolar manic episodes on top of a psychotic issue. And the treatment, I think, is pretty logical. Since you have psychotic symptoms and you have affective symptoms, you treat them both. You treat with an antipsychotic and an antidepressant. So what about our third patient with major depressive disorder with 3 years and then recently begins hearing voices telling him he's worthless and to kill himself? Yeah, so here's our major depressive disorder with psychotic features. Oddly enough, the treatment is the same, and that makes sense if you think about it. So there's psychotic symptoms, there's affective symptoms. You have to treat them both. So the difference is really only in the label, and that has to do with what comes first or what happens in the absence of the other. One thing to remember about psychotic depression is it is one of the indications for ECT, electroconvulsive therapy, especially if they're pregnant. Right, because a lot of those medicines we use to treat it are contraindicated in pregnancy. So if you see psychotic depression, that's one of the times that ECT as an answer choice would be correct. So what about our fourth fellow? He's convinced Miley Cyrus is in love with him, but is otherwise functional in his day-to-day life. Delusional disorder, very good. So this one specifically would be the erotomanic type because it has to do with having a delusion that someone loves them that doesn't, usually someone famous. These delusions are almost always, or are always, non-bizarre. So there's something that could happen. It's not like, oh, this guy thinks that aliens are coming down and stealing his children. No, it's something that's believable, non-bizarre, but still a delusion. And these are better treated with psychotherapy. You have to develop a therapeutic alliance with the patient because they don't believe what they have is a problem. They truly believe their delusion, hence making it a delusion. So, any questions so far?
You know what med you put them on?
An antipsychotic. I think it would depend on, if they're functional, probably wouldn't shoot them up full of haloperidol, but since it's a type of psychotic disorder, I would assume an antipsychotic. Okay. Question or hand gesture?
For the schizoaffective one?
Yes.
How does he fit the criteria for schizophrenia if he only has secondary delusion? I thought you need two.
Good. So the question was for y'all in Harlingen, they were questioning why my second patient met the criteria for schizophrenia. And you're right, I didn't give you enough information in the vignette to make that. So to diagnose schizoaffective disorder, do you have to meet the criteria for schizophrenia, the psychotic symptoms, diagnostic of schizophrenia, with mood symptoms on top of it. Space was scarce in my PowerPoint, so I apologize. That was a good catch. Okay, any other questions? All right, so our agitated psychotic patient, what should we give them? Haloperidol would be the drug of choice for first line, just because it has a faster onset, and if the person is really agitated, anytime you see in the vignette, you can't get the history from a patient because they're so agitated, they're hurting nurses and orderlies, they're so agitated. The drug of choice is always going to be an IM drug because it gets there faster, you don't have to establish IV access, and haloperidol has a quick onset of action. And how does haloperidol work? I think we've said it before. It's a dopamine blocker, D2 specifically. So it blocks the D2 dopamine receptor, and it blocks it everywhere, at each of those 4 tracks that we saw on one of the prior slides. So because of that, and knowing those 4 tracks that are there, since it blocks non-selectively, the blockade at the tubuloinfundibular tract is going to cause hyperprolactinemia and lactation, galactorrhea, and at the nigrostriatal tract is going to cause EPS. So knowing that neurobiology helps you answer those questions. So what are the low-potency antipsychotics? Very good. And it's hard to remember those because we don't use them, right? Have you ever seen a patient on these? I don't think I did when I was on my psychiatry rotation. But what to know about them for the test is that they're low potency, so they have less EPS effects, but they are more anticholinergic. So think back to Dr. Keaton in pharmacology and remember those anticholinergic side effects. If you see a patient or if you're reading about a patient on your exam that's got the dry mouth, blah, 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 they may have too much of this or be intolerant of one of these low potency medicines. And the high potency antipsychotics? Good, good. Haloperidol and flufenazine are the ones that you'll be tested on most because they're higher potency, they have higher EPS. And what if you have a patient with medication non-adherence, which is the PC term for non-compliance, just so you know. They won't take their meds. You give them some antipsychotics, they're too psychotic to take them. They'll throw them away. You can give them an injection. So flufenazine is available it's called the decanoate form. You can give them every 2 to 4 weeks, and that's good if the patient is not reliable to take an oral med.
Why would you go with a typical antipsychotic here instead of doing the Risperdal concert or something like that?
So Risperdal is the other one that's available in decanoate. Decanoate is just the type of injection where it's like a depot form. It lasts. So both haloperidol and Risperdal are both available in the long-acting injectable.
Okay, so decanoate is just a delivery term.
To my understanding, yes. I think you can have Risperdal, decanoate, and haloperidol decanoate. That's my understanding. So these are some random side effects of some random medicines. Purple-gray metallic rash over sun-exposed areas and jaundice. Very good. Chlorpromazine. And the prolonged QTC and pigmentary retinopathy is thioridazine. So why do we care about a prolonged QTC? Because it can lead to torsades and death. So it's rarely used, it's a rare side effect, we care about it, and they test you on it because it kills people. So remember these. I think one of these showed up on my shelf. I can't remember which one. Okay, so a patient on an antipsychotic wakes up, suddenly their eyes are stuck looking up, their head is stuck looking to the side. What's this called? Dystonic reaction. Usually it's the earliest onset. It happens within 12 hours. The treatment of this is important. You treat it with benztropine or diphenhydramine. So they often ask you, they'll give you a presentation of somebody with one of these side effects and ask you how to treat it. The first treatment is obviously stop the medication that was causing it. But these that I've given on the PowerPoint slides are the medications to treat it. Patients feeling like they always have to move around, akathisia, and what do you treat it with? Benzo or propranolol. You treat it with the same thing you used to treat social anxiety. That's how I remembered it. Because they're kind of restless, they're moving around, kind of like people who have social anxiety or restless. That doesn't really work. But it's the same drugs that are used to treat both. So, and this onset is within 1 to 3 months. It happens a little bit later. What about a coarse resting tremor, masked facies, unsteady gait, bradykinesia, Parkinsonianisms, and EPS? Usually happens before 6 months, but it's later in onset. And the biggest thing here, they're going to put L-DOPA or carbidopa or something as an answer choice. Don't pick it because it's wrong. You treat this with benztropine or diphenhydramine. Bromocriptine and amantadine are second line, but never, never, never L-DOPA. Why not? Right. Why would you give a psychotic patient L-DOPA? Right. What's the problem in schizophrenia? Too much dopamine. So even though they look like a Parkinson's patient, you don't treat them like a Parkinson's patient because they're schizophrenic. So the latest onset side effect after 10 years, they move their tongue around, they grimace, tardive dyskinesia. And what do we use to treat it? Yeah, we can't treat it. The best we can do is stop whatever antipsychotic they're on. Clozapine is a little bit less likely to cause it. Olanzapine is also less likely to cause tardive dyskinesia. But, oh no, that's not right, just clozapine. So clozapine is the one that's less likely to cause tardive dyskinesia, which is what you switch them to. So the one that they'll probably ask you about, within moments of a haloperidol injection, elevated CPK, febrile, rigid, autonomic instability, temperature, blood pressure all over the place, and they're delirious. Yes, neuroleptic malignant syndrome. Expect a question on that and know how to treat it. So obviously, look at your answer choices. If stop haloperidol is there, please pick it because it's the right answer. If it's not there, look for things like dantrolene sodium, bromocriptine, and cooling blankets just for symptomatic treatment of the fever. And then remember that there are medical medicines, internal medicine medicines that can cause it also. Metoclopramide is probably the one you'll see because it's used the most. So, okay, so which atypical agent has the highest risk of EPS and elevated prolactin? Risperdal, very good, risperidone. But this one comes in a depot shot, as we discussed earlier, so that's why people still use it sometimes. Decanoate, yeah. So I don't know how high yield that one word is, but I came across it in my reading. So which antipsychotic is weight neutral but prolongs the QTC? Ziprasidone, very good. So there are two atypical antipsychotics that are weight neutral. Ziprasidone is one. What's the other one? Starts with an A. Aripiprazole. So very good. So these two, remember these two are weight neutral. Akathisia, aripiprazole, both start with an A, which is how I made that association. And then QTC is kind of like QTZ. I don't know. So, but those are the two that are weight neutral. They just have different side effects. So the atypical associated with weight gain, olanzapine. Olanzapine makes you eat everything. And causes orthostasis because it's alpha-1 blocker. Which one haven't we used? Quetiapine. So quetiapine, in addition to its atypical antipsychotic effects, also blocks alpha receptors. So it causes orthostatic hypotension. And then what atypical antipsychotic is good for treatment refractory schizophrenia? Clozapine. And what's the most common side effect of clozapine? Is that the most common one? It is the most dangerous one. Yeah, so weight gain, sedation, and then the reasons why you check your patients sugar and triglycerides every so often, or because it can elevate lipids and sugar. The most dangerous side effect is agranulocytosis. It also decreases the seizure threshold. So we always think about what antidepressant in people with seizures or bulimics or whatever. Yeah, bupropion, but clozapine also decreases the seizure threshold. And for monitoring, we want to check a CBC to make sure we catch agranulocytosis and stop the medicine if the white blood cells go too low. Okay, so we have a woman complaining of decreased appetite, 5-pound weight loss, doesn't enjoy knitting, she's got insomnia, no energy, can't concentrate, feels guilty, all for 2 weeks. What does she have? She's depressed, yes. So this is a depressive episode. What's the most important first question for this patient? Very good. You assess for suicidal ideation first, just because you always want to think when you're asking questions or planning your workup, what's going to kill the patient? In suicide, that would be, in depression, that would be suicide. So risk factors for suicide?
Single white male, they're old and live at home by themselves, recently divorced with firearms and alcohol.
Oh, press your button and say it again.
Previous history of suicide?
Very good, Harlingen. That's the most important risk factor, is a prior attempt of suicide. But everything you said comes right after. Single white male, lives at home, unmarried, divorced. Alcohol, firearms, have a plan. All of those are other risk factors. But the most important one, if you get a question asking for the most important risk factor, it's prior attempt. Oh, you know all of them. Look at you.
Suicide risk assessment.
Okay, so here are some kind of random medical questions they might ask. In a depressed person, what happens to their sleep? What might you see on a polysomnogram? Yes, so, wait, what did you say?
REM is switch beginning to sleep.
Yeah, so you have a shortened REM latency. That means it takes less time from when your head hits the pillow to when REM sleep starts. And there's also more frequent REM. So does that make sense why depressed people are tired and fatigued all the time? They got more REM. Yeah, so remember, and we'll get to sleep in a little bit, but 3 and 4 sleep is the most restful and restorative. REM sleep, your eyes are moving all over the place. It's like being awake. So I think it makes sense why there's shortened REM latency and more frequent REM. And this is kind of random, but an atypical lab test in people with depression. It's not really used clinically, but it's a hormone level that's high in patients with depression. It is cortisol. So the dexamethasone suppression test is abnormal. Their cortisol level is high, so when you give dexamethasone, it doesn't suppress in the blood. And medications that might cause depression, there's a whole bunch of them. Give me some main ones. Beta blockers, interferon gamma, and alpha-methyl-dopa are the 3 big ones. There are a laundry list of others. And then don't forget drugs of abuse. You can't diagnose depression unless somebody is off drugs and done detoxing from drugs. And medical diseases that cause depression, again, there's a laundry list. It kind of depends on what other symptoms they give you in the vignette. HIV, they tell you about the risk factors, seroconversion disorder. If a tick bit them, think Lyme. Always check thyroid. That's one of the first medical tests you take. Porphyria, if they've got abdominal pain or joint pain or a photosensitive rash, that's probably porphyria. Uremia, if they have kidney failure, and so forth and so on. So those are kind of the big ones. Oh, left middle cerebral artery stroke. That was a question in pretest that I got wrong like 85 times in a row. So I decided to put it on my slide. A left middle cerebral artery stroke gives the patient symptoms of depression. Okay, first line drugs for major depressive disorder. SSRIs, they're our best friend in psychiatry. Other indications for SSRI are OCD, bulimia, anxiety, PTSD, and premature ejaculation. Por qué? Why premature ejaculation? Well, think about one of the side effects of SSRIs. Yeah, so it decreases ejaculation, so you can actually use it in the treatment of premature ejaculation. I haven't seen it used, but it's in the books. So, which SSRI has the most drug-drug interactions? Paroxetine, very good. It has the most interactions with cytochrome P450, so more drugs will cause problems. What drug don't you have to taper when stopping? Fluoxetine. And why is that? It has the shortest half-life, so you don't have to worry about serotonin discontinuation or SSRI discontinuation syndrome. Which one has the fewest drug-drug interactions? Very good, citalopram. And if your patient was on an SSRI and gets headache, nausea, vomiting, diarrhea, dizziness, fatigue when they stopped it suddenly, which one might they be taking? Sertraline and fluvoxamine. Sertraline is probably the one they'll ask you about. So this is serotonin discontinuation syndrome. Kind of feel like they have the flu.
Isn't fluvoxamine or Luvox only indicated for OCD, not antidepressant disorder?
That's a good question. I don't know the answer to that. It was listed with the SSRIs, so I put it in the SSRIs section. But I didn't come across it in my reading, and I don't know. Sorry. But I trust you if you say that's true. Harlingen, he said that fluvoxamine is only indicated for OCD and not for MDD, but I don't know about that.
It's in the pharmacopoeia.
Apparently it's in pharmacopoeia.
That's the only reason I asked. I made a presentation this morning.
Well, then I trust you. Okay, so what if your patient has myoclonic jerks, tachycardia, high blood pressure, hyperreflexia, nausea, vomiting, diarrhea? What does that sound like? Serotonin syndrome. So you might get this with a high dose of an SSRI, or if you combined SSRI and MAOI. And we talked about loss of ejaculation and erection. What should we switch them to? Bupropion. Very good. And the mechanism of that, it's dopamine, norepinephrine reuptake inhibitor. When can't you prescribe bupropion? Yeah, seizures. So if someone's epileptic, if they're alcoholic, because they're at risk for DTs and withdrawal seizures, or if they're bulimic, because their electrolytes get all screwy when they're throwing up all the time. Erection lasting more than 3 hours? Yeah, trazodone. See a doctor, but it's probably caused by trazodone. Which antidepressant is good for old, skinny, sad ladies? Mirtazapine, very good, because it increases appetite, is sedating, and has antidepressant properties. Very good. What antidepressant should you avoid in hypertensive patients? Venlafaxine, very good. You also shouldn't take it with St. John's wort. There were a couple questions on my shelf asking about drug interactions with common herbs. This is the only one I found in my books, so I put it on there. So St. John's wort and an SNRI can cause a hypertensive crisis. And our last patient, pounding head, flushing nausea, myoclonus, after they ate some cheese and drank some wine. Yeah, so that's a hypertensive crisis with MAOI. And you treat that with an alpha blocker because it's the excess of norepinephrine that's causing these symptoms, and alpha blocker IV is the treatment. Okay, so we got a little kid. He ate some pills out of grandma's purse. Grandma, these are her medical conditions: hypertension, hyperlipidemia, fibromyalgia, insomnia, peptic ulcer disease. This kid now has dry mouth, tachycardia, vomiting, urinary retention, and seizures. And an EKG, I know you're thinking, I'm not in medicine. I don't need to know EKGs. So they probably wouldn't give you the EKG. What they would tell you is that there's widened QRS complexes and a prolonged QT interval. What did the kid get into? A tricyclic. Very good. So I didn't say grandma had depression, but TCAs are also indicated for insomnia and fibromyalgia. So grandma's taken a tricyclic. The kid ate the tricyclic. And what's going to kill him? Yeah, an arrhythmia. Torsades from the prolonged QTC. And we treat it with charcoal if you get them in time, and then sodium bicarbonate. Helps the metabolic acidosis and is somewhat cardioprotective. So that's the treatment. Okay, so a patient. They're sad. They're eating a lot, gaining weight, sleeping more, and the buzzword is leaden paralysis in the morning. That's atypical depression. I don't know what the leaden paralysis is about, but that's the buzzword for atypical depression. Also, they sleep more and eat more instead of regular depression where they usually eat less and sleep less. And this is a good indication for MAOIs. If we've got a patient 1 month after the death of her child, feels guilty, can't sleep, concentrate, eat, or enjoy her interests. Good, bereavement. So this is uncomplicated bereavement. It's expected based on the loss that this woman suffered, and she does not have suicidal ideation or psychosis. So remember the little caveats in this DSM diagnosis. Thoughts of death are okay if The mom wants to be with the child, thinks about what if it were me and not my child. Those types of thoughts are normal, but suicidal ideation, plain and simple, is not normal. Hearing the child's voice in the nighttime is normal, but frank psychosis is not normal. So this woman would qualify for uncomplicated bereavement. Remember, this is one of the few things that goes on the V code. It's not a mental disorder, so it's not an Axis 1. It goes on the V code of DSM-4. What about our last lady? 4 months after the death of her chihuahua, she feels guilty, can't sleep, concentrate, eat, or enjoy her interests. She started feeling this guilty 2 months after her chihuahua died. What did you say? Pathological grief or adjustment disorder. Yeah, so the DSM term is adjustment disorder, and the symptoms have to start within 3 months of the stressor, can't last longer than 6 months of the stressor, and must be out of proportion with what would normally occur. So think about this. Usually they'll describe a child that goes away to college and has problems adjusting, so they call it adjustment disorder. But the symptoms stop just short of major depressive episode. Okay, and this is one of the indications for psychotherapy, a good therapeutic alliance, and working through the issues with adjustment disorder. Okay, so a patient is brought in by his identical twin brother, stating he's been sleeping little, had sex with lots of ladies, talks in a pressured manner, maxed out his credit cards. He's starting a business that couldn't fail. What does he have?
Bipolar manic phase.
Yeah, so this is a manic episode. We don't know if he's had any depression, but definitely a manic episode, possibly bipolar if we see cycling. Incidence in the general population. What's the magic number? So it's 1% incidence. Risk for diagnosis in this identical twin brother? 90, yeah. Bipolar disorder is one of the most heritable psychiatric conditions ever. So 90% concordance rate within monozygotic twins. And what would we think if the same symptoms happened in a 75-year-old man instead of this, I didn't say how old he was, but someone in their 20s? So it could be PICS, it could be frontotemporal dementia. There's definitely loss of inhibition, and you can see some of these issues. In general, you'd be looking for something more medical. We'd feel more comfortable calling this a manic phase in someone who's